We've got folks from all over the country, from Germany, Oregon, Boston, Denver, to Florida, where a Super Bowl will be. Yes. Boston. And folks have the choice of having their video camera on or off. I think what I'll go ahead and do some preliminary comments here and welcome everyone.
Hi.
So let's just say hi quickly.
You bet. Hi there.
Kian. Hi, Kian.
Hi. And Kian's on too. Yay.
Hi. Hello.
Hi there, everyone.
I'm trying to do the math and determine what time it is in Hamburg, Germany right now.
Is it about 1 in the morning? I think it is, something like that. Because we had the German folks on earlier in the week. About 1 or 2 in the morning.
Well, I speak a bit of German, and I'm always looking for a chance to practice it. So I might just give my talk in German for them staying up so late.
For their benefit.
Yeah.
Sure.
2 o'clock.
Okay, good. Well, I'll just welcome everyone to our SADS Foundation's 5th webinar in our Living with SADS series on CPVT, or Catecholaminergic Polymorphic Ventricular Tachycardia. I'm Marcia Baker, and I'm the Program Director for the SADS Foundation. Before beginning the webinar, a couple reminders. 1, please keep your audio muted during the PowerPoint presentation for improved sound quality for all. 2, following the presentation, we'll have an allotted time for Q&A. And you may type your question in the chat anytime during the presentation, and we'll address those questions at the end of the presentation. 3, today's webinar is being recorded, and it may be accessed later on the SADS Foundation's YouTube channel. And after our Q&A, please stay with us for an informal social chat and get to know one another in the CPVT community. Also, we're going to do a new thing for SADS. We're going to have a poll for the entire community, and we'll be putting up the poll questions shortly. And then the results will be shared at the end of our Q&A right before we begin our community chat. So stick around to see those results of the questions that we put. There's 7 questions in the poll, so feel free to answer those whenever you see fit. So first, I'd like to introduce our speaker now, Dr. Shu Sanatani, who's the head of the Division of Pediatric Cardiology and Medical Director of the British Columbia Children's Hospital Heart Center. He obtained his medical degree from the University of British Columbia, completed a pediatric residency at Queen's University, and a pediatric cardiology fellowship at the University of British Columbia, with advanced training in cardiac electrophysiology at Toronto's Hospital for Sick Children and the University of British Columbia. His clinical interests are in cardiac electrophysiology and focus on understanding and preventing sudden unexpected death due to cardiac arrhythmias in children. He also directs the CPVT registry and biobank, of which I think that's what, Rachel, you were talking about, that your daughter is a part of, right? Dr. Sanatani also volunteers as a medical advisor for the SADS Foundation's Scientific Advisory Council. So it's my pleasure now to welcome Dr. Shu Sanatani.
Well, thank you so much, Marcia, and thank you to all the participants for taking time out of their schedules and joining me. I certainly want to acknowledge the wonderful efforts that the SADS community does and has been doing, especially in these zoomed in times where we are not getting together nearly as much as we'd like to. And so this connectivity, even if without being in the same room has been absolutely great. I'm really honored to be speaking to you. Now I see that my talk has been superseded by a questionnaire, so I'm going to let you guys carry on with the questionnaire and jump right in. Even though I've prepared this sort of as a somewhat structured talk, feel free to to put your questions into the chat group as they come up. And if if they find that, oh my God, 20 people have just said, what the heck did he just say, please stop me. And because this is really about all of us just having a dialogue. So let me figure out how to advance my slides as the first challenge of the day here.
An arrow button?
Arrow button. Yes, thank you. All right. So we've seen all this. So we're going to be talking about catecholaminergic polymorphic ventricular tachycardia, or CPVT. Now, CPVT, not unlike some of the other better known conditions, long QT being the main one, was also described, or first described about 60 years ago in this report in the American Heart Journal. And this was, like many cases of CPVT, familial. A little unusual to have so many children affected, one of whom passed away. And so it wasn't until many years later, though, that the label CPVT came to be. But this report here was certainly one of the first known cases. And they did suspect that there was something wrong, and they were very insightful. Myocardial metabolism, so something around the energy of the heart cell, which is, as we know now, really close to the truth. So when I speak to what are diverse groups of expertise, I probably offend some with the basics, and I probably leave a few behind with the stuff, and then I offend almost everyone at some point with some inappropriate joke. So please bear with me. We're just going to remind ourselves what a normal heartbeat looks like. And a normal heartbeat, and a big thank you to my research team who can pull slides like this from the internet. I say, what does a normal heartbeat look like on the internet? So here we see a cartoon of a heart and the electrical signature of this, and the letters assigned to the electrical heartbeat, PQRST, are pretty well known. Now we know that CPVT doesn't use the letters, not like long QT syndrome. And there's so many of these alphabet soup experiences in our whole channelopathy world. We talk about things like long QT, we talk about QT intervals, we talk about WPW and all that kind of stuff. So doctors love using letters to confuse us all. So anyways, normal heartbeat comes from the top chamber and then spreads through very specialized cells to the bottom chamber. And the impulses that start in the top chamber come from something called the sinus node. Nothing to do with the sinuses that are congested during allergy season or in the cold. This is the sinus node. And so the sinus node is one of the most sophisticated structures in the heart because it knows how fast your heart wants to beat. And so you go up the stairs and it gives you just a little bit of extra heart rate. You are very nervous. You're giving a talk to the SADS parent group and your heart beats a little faster, or you're in a deep sleep and your heartbeat goes slower. So this control of the heartbeat is really, it's one of the most complex and sort of, we take it for granted, even though it's really remarkable. Now, the sinus node does most of the work most of the time. Every once in a while, another pacemaker is going to take over in the heart. And I use the term pacemaker very deliberately. There are pacemaker cells in the heart, and almost every heart cell can beat on its own. So when you take a cell from a heart and you preserve it just properly in a dish, you can sometimes see it beating on its own. So the heart has the ability to contract on its own. So it's not surprising then that other areas of the heart might say, hey, I want to get in on the action. And those other areas of the heart sometimes are very normal appearing cells. Other times they're areas of diseased cells, or in CPVT, there's something in the cells themselves that lead to the abnormal heartbeat. So this is just a very, very cool graphic, I thought, that shows the bottom chamber. And if you look closely, the top chamber is not going as fast as the bottom chamber. The bottom chamber has just said, I'm going at this rate for whatever reason, whatever process has set this off. And that's ventricular, because the bottom chambers are the ventricles, tachycardia, fast heartbeat. So ventricular tachycardia is usually something that strikes fear into almost all doctors and nurses and healthcare teams. The reality is there are some forms of ventricular tachycardia which are not as scary. So it's possible to have some kids, in fact, who have a benign form of this. As we know, though, CPVT is not one of those benign forms. And in fact, CPVT ventricular tachycardia is usually in the worrisome category. So that's just a quick reminder of what a normal heartbeat would look like. Now, it was many, many years after that original description that one of the most insightful and beautiful descriptions of this condition was published. And I use the word beautiful because so much of the diagnosis is contained in this paper. Antoine Lienhart, who's one of our collaborators in France, wrote this in 1995, and it was 21 children. One of the things that's really striking, they were about 8 years of age, but many of them were only diagnosed 2 years later. So, and I suspect when we get to the conversation part, some of you will have stories of, you know, how long it took to figure out that we had CPVT. The symptoms are almost always triggered by stress or emotion or physical activity. And stress is such a nebulous concept. We're going to talk a bit about stress later on. About 1/3 of them have a family history, which is true in our experience now. About 1/3 of the kids that we see have a parent who also has a gene for CPVT. And sometimes the kid is the first one that's diagnosed in the family. The heart is usually normal, and the QT interval is normal. And here's bradycardia. Now, you've heard me talk about tachycardia, fast heartbeat. Bradycardia is slow heartbeat. So the sinus node, for some reason, is often not totally normal in CPVT. So the child will often have a resting heart rate that is lower than normal, even before doctors have started any medication or done anything. And then even back in this series, the treatment with beta blockers was well studied, and it was recognized that missing doses or not taking the doses as prescribed could result in treatment failures. And that's a common theme in both CPVT and long QT, where we talk about the importance of taking your medication consistently. And the body just gets confused and then doesn't really know what's coming. Now, that paper really was just before some of the other big insights in CPVT, including a much better understanding. So here you see that, again, the arrhythmia. So here is a normal looking heartbeat with a very normal looking tracing, and then a much more disorganized one that's wide and just doesn't look like it's going to lead to an effective heartbeat. Interestingly, CPVT, though, also has abnormalities in the top chambers. So in the atria here, including the sinus node can be slower, and young people can have atrial arrhythmias. Lots of people have heard about atrial fibrillation. Atrial fibrillation is one of the most common conditions that affects people as they age. And occurs in about 10% of the aging population, but CPVT kids can have it even more commonly than that. Now, here's one of the really unreassuring remarks that I'll make. The ventricular tachycardia, well, it can stop on its own. It can just occur and the child doesn't even know it or may just have very minor symptoms. It can progress and cause a collapse or even sudden death. And so I'm not saying this to be to frighten anyone that there might be some VT going on in the background. What's really remarkable is how well some people can cope with this, with the ventricular arrhythmia. And I've had children on the treadmill where the arrhythmia looks very disorganized, and I'll be saying, are you sure you want to keep going? Do you want to stop? And the kid, just continues on and says, I'm feeling a little bit tired. Maybe I'll stop. So the tolerance of the arrhythmia is very variable. So to put things into perspective, how common is CPVT? And we haven't got really great data about how common this is worldwide. We estimate that it's about 1 in 10,000. And people like me anyways, we don't really know what that means. Like, we can do some math and figure out, well, then there should be, several more hundred cases in our country than we have, or 1,000 more cases in your state. So we're obviously not diagnosing all the cases, but it's probably out there more than we know. It's about 5 times less common than long QT syndrome, but long QT syndrome is much better understood, much more readily identifiable. It's about as common as type 1 diabetes. Now, diabetes, though, is, got great publicity. Everybody knows about diabetes. People aren't really confused about diabetes, and you're not as likely to miss the diagnosis. So why the disconnect? Well, here's some other numbers. Asthma is pretty common. Asthma is probably a little bit overdiagnosed. And then, women develop breast cancer at an astounding rate. So we're glad CPVT isn't more common. We think we're probably under-recognizing it. We've been doing a registry for several years, and the registry is a bit complicated, and I'll talk a bit about the structure of that later on. But we have about 163 patients with CPVT in our registry. We have several more family members and some parents in there also. But this demonstrates how uncommon it is at each center. So America has more pediatric cardiologists than any other country in the world, but each of them will only have a very small experience, and some centers may only have 1 or 2 patients. So it's not uncommon to encounter physicians that haven't heard of this or don't look after it. So how do we diagnose CPVT if it is that hard to diagnose? And that delay of 2 years is not unusual. When we wrote one of our first papers on our registry, we had about a 2-year delay in diagnosis. Sometimes the delay was even as long as a year after a dramatic presentation with, an exercise-related faint or something that we hope triggers a red flag. Now, the history is the first clue, and it's often a faint. Sometimes it's a family history, and as genetics evolves, one can be identified to have a risk for CPVT before one is even, born, in theory. And then the real diagnostic test that we rely on heavily is the stress test or the exercise test. Now, why is it hard to diagnose? And, a bit of a shout out to my frontline doctors out there. So I'm a very specialized person that doesn't see a lot of variety compared to what an emergency doc or a family doc sees. So I see things from a very different lens. So usually when I hear a story about CPVT, it sounds fairly suspicious. But CPVT is very uncommon, and all the usual tests that we do are normal. fainting is extremely common. Probably 1 in 3 people faints. There's probably some people on the call who have had faints, and some of those faints are not worrisome. And then other diagnoses are just more well known. There are things that are taught in medical school that people will never see. There are lots of conditions that my daughter is studying. She's in medical school that she is never going to see, even if she travels to the most wildest parts of Africa. But you can't teach everything in medical school, and it's hard to design a perfect curriculum. This year, people are learning too much about a virus that we don't really want in our lives at all. And how important is this virus going to be 10 years from now? I don't know. So anyhow, it's hard to teach people everything. The other thing is that the heart is structurally normal and the exam is normal. So when you listen to the child's heart, or when you do an echocardiogram, an ultrasound of the heart, it's usually normal. So there's very few red flags that come up in the usual presentation. Now, fainting. I mentioned fainting is very common. The key to diagnosing fainting is taking a good, thorough history by someone who is good at taking thorough fainting histories. And we try and simplify this. And we don't want to see every person that faints in a specialized cardiogenetics or inherited arrhythmia program. We just couldn't do it. We don't want to do genetic panels on everyone that faints. That's going to generate a lot of noise, a lot of false positives, because some of us carry genes that won't ever affect us, or we carry genetic abnormalities that won't affect us. So we don't want to create a panic. So what do we want to do? Well, we want to find the people that really need to be seen by the specialist. One of the other confusing things is that it is possible to have a normal kind of faint and have a serious life-threatening problem also. Now, we get calls sometimes from our patients who have known arrhythmia conditions and they've had a faint, and we'll go through the story in great detail, and we'll say, well, this is a really worrisome faint, we need to increase your meds. Or wait a sec, you've had the kind of faint that 1 in 3 people have. You need to not skip breakfast and go out and do so much in a day when you've skipped breakfast. So that's really one of the confusing elements. Now, I have no idea what these little symbols mean. I think it means it is very hot out, you're about to faint. Now, the other thing is that a lot of people will faint and never be seen at all, because fainting is so common, and someone will say, well, I used to faint all the time when I would see blood or get a needle poke. Now, the red flags I look for, I've sort of shortened the list here. Certainly any fainting in water is worrisome. CPVT can be associated with near drowning, even in a capable swimmer. A mid-activity faint is also worrisome. So I was running, I was going to win the 800 meter. The next thing I know, I woke up in the nursing office. So when you don't have time to slow down and stop, that's worrisome. Those are sort of blatant ones. The more subtle ones, and part of the reason for the 2-year delay in diagnosis, are things like, well, I was late for class, I was a little bit nervous, I was running to get to class and I passed out, but I was nervous. And that's the kind of story that we want to say, well, it's probably okay. And so someone like that might, be reassured and never seen. Now, if you do get to the point where you get to have a specialist conducting your stress test, and I very deliberately kept this picture in, because this is where the stress test really has its origins. The stress test is for old guys who have heart disease, And when they walk a bit, they, oh my goodness, my chest really hurts, and they have ECG changes. The stress test isn't designed for a 10-year-old who normally runs around on the soccer field or on the basketball court and then has an arrhythmia. So what is that? Why am I telling you this? So you really need to get the stress test done by people who know what they're looking for and who are going to let the kid keep running after the few extra beats that otherwise might trigger them to stop. So this poor technician in a small town hospital, she's only seeing this business executives for his stress test. And when he starts saying, oh, it hurts a little and he's got extra beats, that's not a good thing, and she'll stop it. So she may not be the right place for the stress test of a 10-year-old being worked up for CPVT. I don't say this to disparage anyone, but I'm just trying to make some sense of how is it possible that such a dramatic condition may be not recognized even after some really bright people have worked on the case. This is a typical, well, no, this is a classic stress test, not typical. It's rare that the patient has read the textbook so closely. So at rest, there is a relatively slow heart rate, totally normal, at around 100 beats a minute of exercise, which is, a brisk walk or a little bit faster, slow jog. These wide beats start coming out, what are called PVCs, premature ventricular complexes. And that is in and of itself an abnormal response to light exercise. But that doesn't mean you have CPVT. There's a few other conditions you can have. As you keep going, and this is where I say you have to keep going, this is not the end of the test, you'd get more PVCs. Infrequently, you may have a very classic pattern of down, up, what's called bidirectional. And this is actually a short run of bidirectional ventricular tachycardia. It's one of the things that's so-called a hallmark of CPVT, but it only happens in about a quarter or a third of patients. So when you find this and the kid is running on the treadmill, you have a confirmed diagnosis of CPVT. Now, as I said, sometimes the kid is like, yeah, no, I feel okay, and they keep going. And then they get into this very disorganized, fairly wide looking rhythm. And this is usually the point where I'm saying, maybe we should stop. Now, we in our program let the patient tell us when to stop the treadmill. So it's very unusual for us to say, okay, that's enough, but this is a good time to stop when you can't recognize what's happening on the screen. Now, remarkably, as soon as they stop exercising, they don't necessarily go backwards one step at a time. They almost go instantaneously back to a normal rhythm. It's very rapid. This is something that we're hoping to put out in the public soon. And by put out in the public, I mean that someone has written a paper about it and the journal is thinking about whether they want to publish it. Bruce is the name of the usual protocol that we would do in a typical adult type patient or in a typical adult setting. And this is a gradual increase. So you get lots of warming up time and lots of lead time, and you start having extra beats. Now, this same patient went through our burst protocol, which is a bit more of a, okay, you're walking on the street, suddenly you see your bus coming. I want you to run for the bus like you need to make it for your job interview, or whatever the story is that gets them motivated. So we have them sprint. And the same patient, his worst arrhythmia on the normal protocol was just these isolated extra beats. When we made him sprint, he actually went into a classic bidirectional ventricular tachycardia. This, you would say, well, I'm suspicious, I'm concerned. You wouldn't necessarily treat him differently. You wouldn't escalate his therapy. This, you would say, you need more treatment. So I'm hoping to be able to share more with you in the near future about the burst protocol. Now, genetic testing is a tool like all the other tools. And I think it's a tool that has really excellent applications, but it's also a tool that needs to be used cautiously. So broadly speaking, we can send some form of tissue. Now, we usually don't send hair or skin, but we usually send blood or saliva. And a lab can then look for spelling mistakes in our genes. And you can definitely have a very broad panel looking at loads of genes, 19,000 genes, or you can have a fairly focused panel looking at CPVT. And my practice is to use as narrow a panel as you can to reduce the amount of garbage you find. So if you have someone that has classic CPVT, you don't actually need a genetic test to confirm or refute their diagnosis. They have CPVT. So why do the genetic test? Well, I want to understand the mechanism of their CPVT if I can, maybe learn about a new type of gene. I want to make sure that I can test the family members for the same genetic variant. But it should not make you discard a diagnosis of CPVT if you think the patient has one. Now, I really like this. And again, thank you to my research team to make these wonderful slides. I love this spelling mistake. So here's a genetic code. It's supposed to say cat. Cat comes out normal protein. One minor substitution. And of course, C and, well, R isn't a usual code in our DNA, but we switched the C to an R and suddenly, oh, not quite as cute. And so there you go. And sometimes just it's a nonsensical spelling mistake. So I really like this, in part as a cat person, but just because it's cool. Now, the genetic code is relatively simple. There are a very limited number of permutations. There's 3 positions that determine the amino acid. And so this kind of simplicity has allowed the explosion of genetic testing. And companies even go to people directly and say, hey, do you want to do your whole genetic panel and we'll store it for you and tell you all kinds of things. I obviously have a bias because I see there's potential risk to knowing things that we don't really understand. So it's a little more complicated to me than that. I believe very strongly that you should not pass, in this case, the genetic counseling. So genetic counseling is absolutely essential. And I'm always disappointed when I see a family when they don't understand how a genetic test came to be done on their family. Not necessarily in CPVT, but I'm sitting with a family that's been referred because they have this variant in that gene and they don't understand the implications. So I'm a big advocate for proper genetic counseling and understanding what it is you're testing for and what it means. Now, there are 5 genes currently that have made this Wikipedia list of genes. There are a few others that are exploratory, and essentially, apart from ryanodine, they are almost all much less common. And so calsequestrin and triidin are probably the more common of the other causes, but all of them share in common a role in the calcium metabolism in a cell. And so how the cell contracts is one of the things that we study. So about almost 2/3 of CPVT are going to have a ryanodine variant. Now, there are people who have ryanodine variants who don't have CPVT. There are people who are healthy who have ryanodine variants. There are people who have other disease. We're about to publish the opposite of CPVT, which is also a ryanodine disease. And then about 1/3 to 40%, we don't know the genetic cause. And we're probably going to learn that it's a few different genes coming together. Long QT is a little bit ahead of us in CPVT in terms of defining multiple genetic factors that contribute to long QT. CPVT, we're still working on it. Now, this is a cartoon of the ryanodine where the calcium goes into the cell and then lets a lot more calcium release. Now, I'm just showing you what looks like a potato, and I don't know if this is going to play. This is a model of the ryanodine receptor, and I show you this just in part to give a shout out to our basic science colleagues that we work with, but they take this structure and then they break it down into much more smaller parts and then can understand how the proteins interact. So here is a spelling mistake that has occurred in the ryanodine, and the spelling mistake results in the protein not functioning. So sometimes we'll get asked by one of our team members or our collaborators, they'll say, we just got this spelling mistake in a ryanodine. We think the patient has CPVT. What do you think? I said, well, I think it fits. So that's important. And when you look at the protein, yes, it does something that would affect protein function. Now I'm moving way slower than I wanted to. So Marcia, I'm just going to keep going until you cut the power on me. Because I want to get to the real meat of the stuff here.
You're fine.
Now, these are some guidelines from the experts on therapies for CPVT. And this isn't the whole list. There's a few other things. Now, one of the things that's important to emphasize is that an ICD should only really occur if you're doing everything else, meaning you're on the right medications, you've talked about cardiac denervation. Lots of people with CPVT have ICDs, and we're going to come back and talk about that in a moment. The hard part about this therapeutic recommendation is the stuff under number 1. Limit, avoid competitive sports, limit, avoid strenuous exercise, limit exposure to stressful environments. Well, I don't know a teenager who isn't in a stressful environment, and most of us in the past year have also had a bit of stress. So stress is one of those things that we really need to understand better when we're telling people, well, avoid stressful environments. So a lot of these are hard to understand. So that's one of the things we're really working on. Now, the medications are, I think, relatively straightforward. Beta blockers work extremely well in CPVT. They're not enough in probably about 20 to 30% of patients. And those patients in the current era should be on flecainide. I have a bias that I think flecainide actually may be more important than beta blockers in some patients, but we generally go with beta blockers plus flecainide. And we're going to talk about the other things on there moving forward. Now, beta blockers basically reduce the adrenaline effects in your heart and cause a slower heartbeat and less calcium release into the cell. So they actually work on the direct mechanism that causes the problem. Beta blockers, I think, get a bad rap from a lot of people because they have a long list of side effects, and especially the adolescents experience some of these symptoms quite naturally. Adolescents are often tired. I've already said that 1 in 3 people faint from low blood pressure, and fatigue is such a pervasive symptom. So I think as long as the patient is started on a low dose of beta blocker and titrated up, and that the beta blocker isn't excessively dosed, I think it works very well. I do have a very low threshold for adding flecainide and reducing the beta blocker when possible. So flecainide used to not be used much in adults because there was a very famous study that said it wasn't good for adults. in our experience, flecainide and beta blockers works very well together. And so here's a slide again. Thank you to the research team. It shows actually that a lot of our patients did much better on their treadmill or even just in their clinical follow-up with flecainide plus beta blockers. So it said flecainide reduced the arrhythmia in 41%, 29 of 71. Now, we don't have perfect data. One of the things about when you work with 25 other centers is you don't always know everything about the patients. And so there are gaps, unknown 21. Now, it's very, very likely that no news is good news in the registry, but we can't assume that. Now, cardiac denervation is something I don't want to spend a lot of time on, but I do want to mention it because I do think it's a growing and important part of our therapy. What basically the surgeon does, or sometimes another type of proceduralist, is they go in through small holes between your ribs and they change the innervation of your heart because the heart is getting too much adrenaline at times, so they change the innervation. Now, this is a procedure that we do and have been doing for a long time. We don't understand all the effects. This is not as simple as changing the adrenaline to your heart. It also changes some of the other hormones around your heart, and it can change your heart regulation in ways that we don't fully understand. And some of the things that we expect, like we expect, oh, well, the heart rate should go much slower, isn't actually the case. Now, we've got a growing experience with this, and I think we'll see more of this as we understand the autonomic nervous system better. But one of the Achilles heels of medicine, period, in my opinion, is that we don't understand the autonomic nervous system well enough. This is a cartoon of it. Now, it gets confusing. The illustration is pretty confusing on its own, but there's basically two limbs, a sympathetic, which is adrenaline, and a parasympathetic, which is counter adrenaline, slows you down. These two nervous systems have to control what you're doing. Now, I've already said that in 1/3 of people, they faint because of an autonomic nervous system misfire. I've also shown you that just getting on the treadmill and sprinting is very different than if we gradually warm you up. And for those of you who are familiar with CPVT or have a family member with it, or you yourselves have it, you are living proof that one doesn't necessarily have a bad cardiac event on the first day of one's life and every day thereafter. There are factors about the control of the heartbeat and the breathing that we don't understand. And some of it is going to come down to how the brain interacts with the heart. So this operation of cardiac denervation probably does a lot more than we fully understand. But certainly if I was a patient and I was on beta blocker and flecainide, and my doctor said, well, you're a very severe case, I think you need a defibrillator, I would say, I want a denervation consult first. I want to understand whether that might prevent a defibrillator. Now, why am I trying to stay away from defibrillators? So defibrillators, again, are designed for that generic old man that was on the treadmill. Defibrillators were designed to prevent people who have established coronary artery disease or poorly functioning adult hearts from dying from arrhythmias. Amazing invention, amazing. Just the brilliance blows my mind. They are not designed for young people, they are not designed for growing people, and they are not designed for CPVT. Now, some people with CPVT absolutely need them and benefit from them, and their lives have been saved by them. Absolutely. There are some risks in CPVT. One of the risks is you get diagnosed when you're 10 and you're going to grow. So this lead is going to stretch or fracture. The other thing is when you're 10, you can get your heart rate up pretty fast. So you might get a shock when you didn't necessarily need a shock, just from your heart rate going fast. Or in CPVT, you can have an atrial arrhythmia, as I mentioned, which might confuse your device. So we actually looked at CPVT defibrillators. And here on the plus side, 40% of people got a shock that was potentially life-saving. Now, I say potentially life-saving, referring back to the comment that some ventricular tachycardia may have stopped on its own. The device isn't necessarily going to wait around and say, well, let's see how this goes. The device can't tell, doesn't check with the patient, how are you feeling? Are you okay? Have you sat down and this is just going to settle down? The device says, I need to go. Now, about 1 in 5, though, got shocks when they didn't need them. And 1 in 5 had something called electrical storm, which is a device firing repeatedly for dangerous arrhythmias, and then that bringing on more shocks. So absolutely important therapy, does have some risks. And again, this is why CPVT discussions really are best held with CPVT clinics. Now, I'm not going to show you this. This is just to make a point that out in the universe, there's a lot of sensationalism. There's a lot of very dramatic things. There's a lot of scary things. YouTube is a wonderful place to find things that are scary, grotesque, probably illegal. The message comes across that activity is scary. And now, if you look at the numbers, this is 25 cases over 15 years. So there's not tons and tons of these events happening, but they are tragic. And the SADS organization is one, world leading example where we've turned tragedy into positive. We've helped so many people. I'm including myself in that although it really, SADS does so much. I shouldn't be taking any of the credit. Activity is scary is a message that's out there. And then when very thoughtful people get together, they even, they're a bit nervous about CPVT. So this patient has no symptoms, but has an abnormal exercise test. And we don't want them doing competitive sports, except for some of those weird ones like billiards or something. Now, first of all, I don't really believe in the word competitive sports in elementary school, because those kids running around or, playing, recreational pickup in the park, or, a bit of flag football, that's not competitive, but there's a lot of adrenaline. And then, when they get into high school, there's a lot of adrenaline and testosterone. So competitive is one of these words that you can put in a guideline that really doesn't mean anything to anyone. One of the very interesting things about CPVT is that you seem to be able to improve your exercise tolerance on the treadmill by training. So more exercise in this study actually resulted in an improvement in their exercise tests. So I'll come back to that. This is one of the only studies about activity in CPVT, led, of course, by Mike Ackerman. And this has about 63 patients in it. And there was no difference between the athletes and the non-athletes. So that's a huge message. The other message that's very important is the people that did have events, they weren't doing competitive sports. They weren't running all out on a sprint. They were doing light exercise. Some of them were having sex. One of them was washing their dog. So, not to freak you out about washing your dog, please wash your dog. Take your medications, though, before you wash your dog. So, in my opinion, the whole thing around activity in CPVT is a little bit like this. Without data, you're just another person with an opinion. So what I find scary in CPVT is the lack of data about activity. And the SADS Foundation has been very instrumental in the hypertrophic cardiomyopathy long QT live study, where we are tracking activity. We're doing a study tracking physical activity in CPVT, not nearly to the scope of the live study or live study, but tracking physical activity. And we're still recruiting families for this. The other thing we're looking at is what's the quality of life like when you have a defibrillator. Quality of life is so important to our families and to the care providers. So our approach to sports in our program is, let's make a plan. And we use this cue card to take us through it. Definitely be talking to the right person, get the right opinions. Swimming is a special case. It should always be supervised. And then even if you're taking your medicine and you have a good stress test, what if? Be comfortable to go to that what if conversation. You don't want to be unprepared. One of the things that we advocate for is CPR awareness, AED awareness. I find it sort of distressing that we have earthquake drills that are provincially mandated and we don't have CPR drills. You are far more likely to give someone CPR than you are to remember what you're supposed to do in an earthquake. The other thing is, you really have to teach these young people to listen to their bodies. That is ultimately the goal. Certainly my goal as a pediatric specialist is when they are 16, 17, they are the ones that are behaving responsibly. They are the ones making the good decisions. I didn't get any sleep. I missed my medicine. I am not going to the soccer practice. I'm going to take my medicine, take it easy. Most of the breakthrough events in CPVT are if you don't take your medicine or if you're burning the candle at both ends. You stay up till 2 a.m., you go off to the soccer practice at 10 a.m., but you don't have breakfast, you down a cup of coffee or something, and then you have something happen. So you do have to pace yourself. But the adults are not good at pacing the young people. The young people have to learn the skill. Just a quick shout out. We are working hard on this in many countries. The green dots are the mostly adult centers, but we collaborate closely with them. And some of them are giant centers like the Mike Ackerman Mayo Clinic Center that is in the adult and pediatric combined registry. And then we have the pediatric registry, which is mostly just kids, but we all work together and we collaborate together. So it's not that there's two separate processes going on. We're very much one and the same research group. I'm just going to say a quick word about stem cells. We have the ability to take a blood sample from a young person and mature it into a heart cell. We can even put in a ryanodine variant, or if it's a patient, we can correct a ryanodine variant. And we can make the cell mature into a heart-beating cell. What we are working on most right now is this actually a CPVT cell? So does it behave like CPVT? Does it have extra beats? Does the contraction work properly? So really assessing the calcium in and out. What does the cell behave like electrically? And then we can do experiments on a cell rather than on people. And we can do experiments that are very much specific to that person. So we can correct their genetic spelling mistake and see if that is the cause. We can test new medications, and we can hope to eventually get to very personalized risk assessments. Now, we are working on this. This is very time consuming, and we're working on scaling it up. So building a bigger factory of cells is one of the things we're doing right now. I just want to close with this. I described a paper about a life-threatening condition as a beautiful description. And I stand by those words. Children very quickly learned how to avoid the stress that might trigger the lightheadedness. So that is one of my guiding principles, is to encourage the child to learn to listen to their body, do it in a safe environment and with the benefit of medication. But a lot of these kids, they know when they are flying too close to the sun. So with that, I want to thank our many collaborators, and I want to thank you for your patience. I'm sure I have gone well into your happy hour, so I will stop talking there and take any questions or participate in a discussion. Thank you.
Thank you very much, Shu. That was wonderful. And now I'd like to open it up for Q&A with Dr. Sanatani, and you can post your question in the chat, or you can unmute yourself and ask it verbally, whichever you prefer. And we have one already that Amy has posted. She says, I have had VT recorded on my ICD during the time I was sleeping. I do not know about it until she didn't know about it until she had her ICD checkup. Is it common to have VT during the time you are sleeping, and why does it occur?
Fantastic. So, well, thank you for sharing that. There was a slide that I wanted to include, and you could tell by my time management that I clearly shouldn't have included any more. But it was the slide that showed that about 20 to 30% of events in CPVT are during rest or even some during sleep. And this was something that wasn't really known until quite recently. And in my mind, I still think of most events in CPVT are in fact when you're awake, when you're doing something stressful or emotional stress. But sleep is a very active state. And when you do a monitor of someone, their heart rate does go up and down, and your brain is doing all kinds of dramatic things during these sleep cycles. And so certainly one avenue is just that you are having adrenaline surges in your sleep. Another possibility, of course, is that the entry into the ventricular arrhythmia is actually coming initially as an atrial arrhythmia. So atrial arrhythmias are less understood and probably occur more frequently during deep sleep. Certainly, atrial fibrillation occurs more when people are at rest or even at sleep. And so one can imagine that the top chamber might go into an abnormal rhythm and then kick the bottom chamber into one as well. So what you really want to do is ask, so I want to know, of course, the first question is, was I actually asleep? And we won't get into what people might be doing in the night, especially the teenagers at night when people think they're asleep. So that's one thing. The other thing is, I would ask the clinician, I say, how did I get into the VT? I don't need to know that I was in VT. I want to know how it started. Could you tell from the device how it started? And those are the kind of questions that your specialist should be asking themselves anyways. And there might well be some therapy adjustments that need to be made.
Thank you very much. Okay, Allison asks, my daughter is enrolled in the cardiomyocyte study, but not sure if she's in the registry. Is there a way to verify or register if she is not part of it already?
Absolutely. We have an email that we will share with Marcia, and then people can just get in touch with us. Most of our centers, people are enrolled through their doctor. There are some doctors or hospitals that are not part of our registry for a number of reasons. It's not everyone has time, resources, or ability to do research. So we made it clear that families could also be enrolled. We will often then have to get your permission to get the information from the doctor, but certainly that we want families to be able to access us. So I'll make myself a note to send Marcia our EP research team's email address.
And we can share it in an email with everyone, no problem.
Yeah, it can definitely go out.
All righty. Jill commented on Amy's question or comment too about my son had repeated shocks during sleep. Carrie has a question. Is it possible for a child that presented at age 4 with a sudden cardiac arrest, is currently 13 years old, on her second ICD, propranolol and flecainide, to ever not need an ICD? She sees Dr. Barul, Charlie Barul in DC.
Well, I'm always a bit nervous when families ask me fairly specific questions, because I think somewhere I probably signed something that said I will not give specific advice to people whose care I have no idea about. So I'll just say, first of all, Charlie Barul is a fantastic doctor and a friend. The question, the way you worded it was, is it possible? And I believe the answer is yes. I believe it is possible to have CPVT that is well managed without a defibrillator. Sometimes getting both the family and the doctor to, to a point where they agree what that means takes some planning and some navigation. Because I hear from some people, well, I take my medicine, but the defibrillator is a nice backup. It's like having a fire extinguisher in our kitchen. We don't have a lot of kitchen fires, but if we ever do, boy, I want an extinguisher there. So there is a comfort in it. That said, if there's a lot of complications or a desire to not have one, there are very good options in optimizing beta blocker flecainide. Consider cardiac denervation. A lot will depend on what your course is and what your arrhythmias are. So it's definitely a conversation that, that a clinician should be comfortable having. I recently had a conversation, this wasn't around CPVT, but I was seeing a daughter of a man. He had been diagnosed with a life-threatening condition, NYD. NYD says not yet diagnosed. So, but he had been not yet diagnosed for 30 years. And he'd never had his ICD go off, and he'd been through about 6 of the things. And I said, thankfully, he wasn't at the appointment, so I could talk freely and talk smack. I said, the guy has had 30 years of monitoring without ever needing a defibrillator. Are we sure he still needs a defibrillator? And the wife was so relieved to hear that, because she thought one just had to continue. Once you've signed up, you just got to keep going. So yes, it's always a good question to keep asking. Now, I don't want to be asked every 6 months, can we get rid of it now? Can we get rid of it now? But absolutely, it's a great question. And the answer should be there. What is it doing for me?
Okay, thank you. Erica from Germany says, we were told it is our responsibility to find other patients or families with the same mutation as we have in VUS. How can I find other patients with the same mutation? Well, I think, Erica, maybe in the CPVT community within SADS, you may find someone with the same mutation. I don't know if you have any other comments, Shu.
I have so many comments.
Mm-hmm.
One of the things that was very confusing was that Erica, I think when I was asking about the time in Germany, she said something about Irish. And so my whole plan of giving the talk in German was foiled, because I think she may be Irish. Now, that said, let's talk briefly about VUS. VUS in CPVT is tricky. The company almost always reports the ryanodine variant as being a VUS because it's new. So many of the genetic variants in CPVT are new, and we don't have the data. We don't know for sure. So we not infrequently get an email from a collaborator who will say, I have a kid, he has classic CPVT. The diagnosis is CPVT based on the treadmill, the story, everything fits. The genetic report came back, said VUS. What do you think? Well, I say, ignore the VUS and go with your clinical diagnosis. It's likely that this ryanodine is relevant. If it's not an absolute, yes, this is really messing with the protein, it's really a big coincidence that you have a clinical diagnosis and a ryanodine variant. Now, a small percentage of healthy people will have ryanodine variants. So we do get also the other emails where we say this ryanodine variant was found in a case of sudden cardiac arrest. There's no CPVT. And then I'll send it. So some of the people that make those cool models and videos, I'll send him a question. I'll say, where does this variant live? What do you know about it? Tell me about it. So I'm always happy to look at variants. And when I say I'm really speaking about those 30 people on the slide. Now, the other way that people have found people with the same variant is they've gone to the genetic company and they've said, can you tell me if you have other sites with this same variant? So there's lots of ways. I'm still kind of curious who would say to anyone, you need to find more people with this variant, because that's a very weird thing to be assigned. That's like extra homework.
Mhm. Okay, Rachel, you had a question on the stress test you'd like to ask. Go ahead.
Hey, Doc. So I was just curious a little bit. I know you were going to mention more about it in the future, about the Bruce protocol versus the Burt protocol. Do you think that perhaps the sprinting triggers an emotional response as well as the physical exertion for CPVT? Because historically for us, I've always been concerned that I always wonder if I'm getting a well enough diagnosis from the treadmill test, because not diagnosis, diagnostic result from her treadmill test, because she'll typically get emotional because of the jerkiness or speeding up and she gets nervous versus the physical exertion. So with the two sides of CPVT being stress or physical exertion or a combination of both, I'm wondering if the leaning towards the Burt is because of that maybe emotional trigger with speeding it up more quickly.
So there's lots to unpack in there, and I'm having, first of all, I'm having a struggle moment, because like when my kids would mispronounce words, I never corrected them because I loved them saying things wrong. But the protocol, I don't want to name it after Burt because then it will be weird. It's called the burst, but
Burst.
anyhow, no, I enjoy it. I love it. So I'm a huge Ernie and Burt fan, but so there was lots there. I have seen kids who don't want to go to the docs because they don't like the way the treadmill test feels, because they know what it feels like before their heart is even going to go out of rhythm, and they hate it. It was like that quote, children quickly learn to avoid the triggers. So, you got to sit down with the dog and say, okay, how are we going to, what's the stress test for at this stage? Are we adjusting therapies, or, what are we doing with it? And, can we reduce the frequency? And I mean, if she's already very emotional about them, then she's probably getting a lot of adrenaline. The thing about the burst protocol is that it is likely the lack of preparedness. So my hypothesis, which is, I think, difficult to prove, is that the surprised brain doesn't do as well as the ready brain. So usually in the Bruce protocol, you're on there, you're walking 3 minutes, then you're a little bit steeper, 3 minutes, 6, and so on and so on. And you sort of know what's coming, and it's gradual, and the brain is not surprised. In the sprint, the brain knows intellectually that you're going to be running in a second, but it doesn't have quite as much time to get used to the idea. So there is a bit of a surprise element. So I think surprised adrenaline is different. Now, there's probably a whole bunch of different responses. I've always thought emotional adrenaline is the really potent stuff. I'll tell an anecdote. One of the kids I have looked after, he had his event not during one of his competitive athletics, which he was very proficient at, but on a school field trip in a hotel pool. And remembering back to the adrenaline that teenagers have on a school field trip, and trying to compare that to, say, racing downhill, or you're running as a wide receiver or something, totally different. So there's something nuanced about the adrenaline that I don't understand, and that I'm trying, and that's why hearing these stories just keeps, every story I hear reinforces there's something about adrenaline that we don't understand.
Thank you very much.
Okay, thank you for all your questions. And Rachel, Allison can share your concerns with her daughter as well, and the treadmill stress test. Let's see. Erica from Germany says, I am Irish. The mutation runs in the Irish family, but we're living in Germany. So,
All right.
okay.
So she's excused from the German lesson. Yeah, and she'll have my team's email if she does want, to talk about the variant or whatever. That would be great.
Okay. And if you know it now, I can put it in the chat too. Or we can wait and send it out later.
The email?
Oh, sorry. It was the way to get in contact for your registry.
I should know it, but I'm going to get one word wrong or something. I wonder
No
I wonder if any of my team is still on there. The poor guys, they probably felt like, oh, we better stay on here before we get fired. I saw, Dania, can you put the proper heartbeat email into the chat?
Absolutely,
Dania.
yeah. I can do that right now.
Dania is one of the stars of our team. She's doing some great work, and she's very much part of why the registry works. Now, a while ago, I saw Bob Hamilton on this call. Now, he's probably clever enough to get out.
He was on. He stayed through the end of your presentation.
I wanted to give him a shout out because I started the talk chatting offline with Rachel about how Jim Perry was an inspiration, but Bob Hamilton, he was my supervisor during my EP fellowship. So I wanted to give him a shout out.
That's probably why he wanted to hear you talk today.
Well, he wanted to make sure I acknowledged his tremendous contributions.
There you go. All right. If are there any other questions? You can put them in the chat, or you can unmute yourself and ask. If not, I want to thank Stu Sanantani again for his expertise and information today. And are there any other questions?
I have a quick question. What are the advantages of being a part of the registry?
All right. Now, do you mean advantages as a patient or a family or as an investigator?
Both. Patient, family, both. Yeah.
Okay. I'm going to just, Dania, please send heartbeat email address. She's probably rolling her eyes. Okay. So I love that question. There are no cash advantages. There are very unlikely to be direct impacts on your personal care in the short term. In the long term, I think it comes down to I think of it very much as a giant ship that is being powered by people rowing. And if the ship represents all the people and healthcare providers that are impacted by CPVT, there could be a whole bunch of people that are just sitting around on the Aloha deck, drinking martinis and sitting by the pool and along for the ride. And I think that is totally fine. That's part of what makes a cruise successful. And then there are some people down below who are rowing, and they're helping us go places. And so I see participation in research, both for myself and for families, as one and the same. We're all basically trying to move this ship ahead in a field of knowledge. So we are at place A, and we're advancing knowledge. And some of the things are going to be amazing. Like, oh my goodness, this stem cell worked to this medication, and I'm talking to this biomed company and they're interested, and wow, we have a drug that's better than nadolol. That's the rare, that's the lightning striking. Most of it is, I go to bed at night and I think, okay, what am I doing to improve my tiny corner of the world? Am I contributing something? Now, sometimes the kids need volunteer hours and activities. And, we say, well, why don't, get involved in this or so. But we leave it very much up to the individuals. And we say, we're all in this together. Every little bit of knowledge helps. We don't know how. But so I take a very philosophical view. I love being able to say to a family, when we looked at this, when we looked at these 200 patients, we learned this. And then I think of a guy like Mike Ackerman, who of course deserves a giant shout out, the president of SADS. And he can do that about, 4,000 papers. He's, when we looked at this, we learned this, we looked at this. So the knowledge, and to be able to take the individual knowledge back to your families is so valuable. That Ackerman paper with 63 participants, that's huge. And that's because some families said, sure, I'll go in the Windland Smith CPVT database. Huge. So without you, we're sitting here on the Aloha deck drinking martinis.
Okay, thank you. And I see the email is, Danya put it in here, so everyone can take a look. Lorraine, hi, I'm glad you could join tonight. She has a question. Is it unusual to get a CPVT diagnosis later in life? 58 years old. I was training for a marathon and experienced symptoms mostly after I stopped exercise. Had a heart monitor on that captured. Now I'm on my second ICD. So is it unusual to get the CPVT diagnosis later in life? That's her question.
It's unusual in the classic form of CPVT that mostly presents in the first, decade or two of life. But Andrew Cron and his team reported a group of women who presented later in life with CPVT who didn't necessarily have the same genetic underpinnings, but had the same basic condition. And so we think it's very much possible. Now, we are usually, as pediatric people, we're diagnosing the kid, and then suddenly the mom also has the gene, and sure enough, her treadmill test is abnormal or slightly abnormal. So we see it that way more. But certainly the other way, as you described, doing a big exertion and then being diagnosed, not unheard of. We just recently put out some data that does show that significant life stressors are more likely when you're going to present with a dangerous heart rhythm condition, so something leading up to it. And certainly most people would say that training for a marathon counts as the significant stressor.
And Lorraine added that her genetic test was negative for CPVT.
And that fits with the paper that SY is the first author, and most of those people were gene negative. Now, the other thing I do, if you're my patient, I ask the guy, I say, how sure are you? I'll go along with your CPVT hypothesis, but you've got to let me ask you every year, how sure are you? And are you sure nothing else is going on? Because CPVT can be mistaken for things and vice versa.
Okay, thank you. Okay, this will be our last question, and then we'll begin our chat with the community. Keiko asks, do you have any special advice for the young adult with CPVT, such as driving, drinking alcohol, loving life?
It's quite a lengthy and painful conversation for the adult or the young adult with me. But thankfully, it's usually a few years in the making. So we start talking about the driving before they're going to get their license, well before they're 16, they have to be demonstrating that they are accountable for the medication. I have an approach that maybe not every parent loves, but the kid is on the hook with me right from the first appointment. And they are the ones that are encouraged to be responsible for their medication compliance, reporting their feelings, hydration, driving. So that, you know, unlike voting, for example, where you're just kind of, you don't know anything and suddenly you get handed a piece of paper and you get to choose your president, you know, this is a gradual iterative process. So we talk about the graded responsibility. We have a generally very permissive attitude with conditions. So there are strings attached. You take your medications regularly. You're responsible for your medications. You have a safety plan. You have an emergency plan. You have a medic alert. You have a friend that knows what's going on with you. All those things. And they've heard that so many times by the time they leave that they can recite it. And so alcohol, the way alcohol kills you is in excess or combined with motor vehicle use. But, you know, a beer or two now and again is not going to kill you. Putting something in your body where you don't know the ingredients, that can kill you. So anything inhaled or ingested where you don't know every ingredient or can't look it up on the internet, that's off limits. So if you're likely to have, you know, if you really like vaping and you can't be sure that it, you know, it's excellent material that's not going to fry your lungs, no, of course you don't put any of those risks in. CPVT is your one allowed risk factor. Everything else you have to be very conservative.
And that last part of it was her love life, not loving life.
Love life, I try not to have the discussion in front of the parents. We have an excellent nurse who goes to all those places. We absolutely talk about about both having kids and having meaningful relationships. We want people to be thriving with CPVT, and you absolutely can.
All right. Thank you very much, Shu. This has been a wonderful conversation. So I will let you go. And I think Aaron's going to create a breakout room for you and Alice. And the rest of us will stay tuned for our poll results. And we can release those now. I think 15 of you completed the poll. And we can begin our conversation. You're welcome to turn on your cameras and we can talk to one another. We have a couple members of our steering committee that will kind of kick this off for us.
All right. Well, thank you all so much for having me, and thank you for your questions. They're always so educational for me. And thank you, Marcia and Alice, for organizing this so seamlessly. And sorry to keep everyone so late.
No, this was fine. We started a few minutes late, I think, anyway, so we're good.
We have nowhere to go, Doc.
All right. Okay. Good night, everybody. We look forward to when we can meet again in person.
Thank you, Shu. All right.
Thanks,
Good night.
Shu. Good to see
Thank you. Appreciate all your information.
Okay.